Good afternoon, everyone. Thank you for joining us. This is our, I believe, third in our series of quarterly swing bed webinars. Lindsay with Stroudwater Associates today will be presenting over swing bed education, skill care, and documentation. So we are a smaller group. If you have any questions, please feel free to put something in the chat. I'll be watching the chat, or you can unmute your lines. Also, if you're watching this recording on our YouTube channel, and you have a question, please feel free to email me. I can reach out to Lindsay and get clarification for you. With that said, Lindsay, I'll turn it over to you.
Great. Thanks, Laura. And good afternoon, everyone. Thanks for joining. Today, we are covering a lot. And it's great that you're going to have a recording. And there's also going to be, we're going to be sending out the slide deck. So lots of information are packed on a lot of these slides. And so really it's also made to be, reference back to them. There's a lot of some like heavy content related to policies, procedures, that sort of thing. So really what we're going to do today is talk a little bit about the definitions and what kind of constitute as skilled nursing and rehab services. And looking at the different areas around observation and assessment, management and evaluation, teaching and training. So we can think about, again, really as it relates to your swing bed program, your swing bed patients. Then we're going to, it's a nice kind of follow into around documentation, in the importance of documentation, why we document, and then the different specific documentations related to swing bed, for instance. So lots to cover. So I'm going to get started, and we're going to just talk about skilled care a little bit. So, the CMS regulations has defined skilled services as really a service that must be inherently complex, that it can be safely and effectively performed only by or under the supervision of a professional or technical personnel. So, any type of service that needs that higher level of personnel to be able to administer, to do for that patient is considered a skilled service. We have an example under here, in an example of a professional or a technical personnel might be a therapist, like a physical therapist or rehab therapist, or a nurse is considered a professional or technical personnel. And then here an example of a patient here at the bottom of this slide is, we have a patient with a plaster cast on a leg. That is not something that person may need any type of skilled care for, but the patient has a pre-existing acute skin condition or needs traction. The skilled personnel may be needed to adjust traction or watch for complications. So this is a patient that their condition requires some type of skilled care. So maybe their chronic condition or whatnot. So again, in these types of situations, and we're going to bring this up quite a bit in this presentation, is the importance of documentation as it relates to skilled care and skilled services. Very important when it comes to articulating that need for our patients. Some additional other areas related to skilled care and skilled services. It's provided to help improve the patient's condition or to maintain it. And we'll talk about maintenance in a little bit in the presentation as well. Maintain the patient's current condition or to prevent it from getting worse. Although we can't, sometimes in some instances, we can't make them better, but we can maintain current condition or prevent any worsening as well. Skilled rehab is care. It's provided to help improve a patient's condition within a predetermined time frame. So a lot of times, we may have on a physician's order or something that they're gonna have some skilled rehab for 14 days, for instance. That is that predetermined time frame that they're going to, hopefully improve, or that predetermined time frame may be when on that maintenance program as well. Skilled care can also help the patients function more independently, or help the patient learn to take care of personal health needs. in any type of care that can be given by a non-professional staff is not considered skilled care. So we need to have, professional staff administer IV antibiotics. And Medicare does not cover custodial care. So again, and other kind of, activities related to walking, eating, or bathing, again, custodial care may be needed for a much longer period of time as well, outside of skilled care. Some other kind of examples of what skilled nursing we need our nurses to be doing. It might be, again, for IV or IM injections or intravenous feedings, enteral feedings, nasopharyngeal and trach aspirations, insertion in sterile irrigation, and replacement of suprapubic catheters, lots of words. Again, some wound care, aseptic techniques. We need a nurse to be doing that. Treatment of ulcers and widespread skin disorders, tracheostomy care, ventilators, infection isolation. We do have some hospitals that are in their swing bed program doing ventilators and trach programs. So again, having that being a highly skilled level of care within our swing bed program. Also, it's always nice to get a whole bunch of different examples, because, these examples help you think about your patient population, your swing bed program, and saying, well, we just got this referral. We didn't know that this would constitute as a skilled service. So we, didn't take on that referral, or we thought that this was not going to be approved for swing bed. So again, I feel like examples of these really helps organizations kind of internally look at what they're currently doing. Heat treatments, again, if it's been specifically ordered by a physician, may require observation by skilled nursing. That can be considered a skilled nursing service. We have rehab of certainly, and rehabilitation of nursing procedures. Maybe it's related to teaching. Maybe you have a patient with needing some supervision of a bowel bladder program, involving administration of medical gases, such as a bronchodilator therapy, care of colonoscopy, something that might be associated with skilled nursing and needs skilled nursing care during that time period. And certainly, again, always if it's justified within the documentation of the medical record, which we're going to talk a little bit about. So breaking it down a little bit more, and oftentimes this tends to be a missed opportunity for a lot of our hospitals, is around observation and assessment. Observation and assessment can constitute as a skilled service when the skills of a technical or professional person, so again, bringing that to the forefront, are required to identify and evaluate the patient's need for modification of treatment or for additional medical procedures until his or her condition is stabilized. So, you may have a patient that was admitted for skilled observation. They did not develop a further acute episode or complication. The skilled observation services are still covered as long as there is reasonable probability. And reasonable probability really means that there is a potential complication or further acute episode was likely possible. So again, your physician making those judgments around reasonable probability, making sure that that is well documented in the patient record around that reasonable potential for a future complication or acute episode. This would meet and qualify for an observation and assessment for skilled care. Some may, document that this patient, it would not be a successful discharge if, X, Y, and Z. Again, following it up, making sure that that is appropriate within the medical record from the physician. So some examples for observation and assessment. You may have, a patient with various signs and symptoms. abnormal or fluctuating vital signs, weight changes, edema, symptoms of drug toxicity, abnormal fluctuating lab values, respiratory changes on oscillation, and then these would kind of qualify for a skilled observation and assessment. These changes would not be typical, and this is what's important. These changes are not typical to the patient. So you have to, they have to be kind of not typical for this patient. So you may have a patient that has kind of like, fluctuating vital signs, but that's a normal for this particular patient. Observation and assessment in meeting that skilled care you have to make sure that it's not typical for that patient. And then, and skilled observation and assessment also may be for somebody that needs are kind of psychiatric in nature, in addition to any of their physical problems. I know that a lot of swing bed programs do not accept folks with mental health, behavioral health, or any type of psych need, just because they don't have the resources for that patient. But again, this could be a way that, meeting some type of skilled care as well. Then we have overall kind of management and evaluation. And so overall management and evaluation of a care plan can constitute as skilled care. So thinking about the care plans that are developed for patients within the swing bed, overall kind of management and evaluation of that can meet a skilled care need. So the development, management, and evaluation of a patient care plan based on the physician's orders, again, can constitute a skilled care related to maybe the patient's physical or mental condition. And activities that may require involvement of, again, the technical or professional personnel to meet some of those patient needs, really to promote any type of recovery or ensure kind of medical safety. And then activities include the management of a plan involved a variety of personnel services only when considering the patient's condition. The aggregate of the services requires the involvement of a technical or professional personnel. And so when we're thinking about activities, it's not just kind of one, we're thinking about the whole kind of picture here. And the various activities together would require some type of skilled personnel that would constitute as a skilled service. Overall management and evaluation, really this is a kind of pulled from the statement within the CMS manual, that management and evaluation of activities are not always identified in the patient record. So we really need to, as I said, really look at all of the documentation and really understand where there may be a skilled care based on the whole patient record. So again, this would be able to kind of constitute as a skilled care as well. And the last kind of one, again, we find that this area around skilled services, around teaching and training, tends to also be a missed opportunity for a lot of organizations. And some examples around teaching and training might be teaching of self-administration of injectable medications or a complex range of different medications, teaching a newly diagnosed diabetic to administer insulin, prepare and follow a diabetic education, observe foot care precautions, teaching self-administration of medical gases to a patient, gait training. Maybe you have a patient that has a recent, amputation, so needs gait training and teaching on their prosthesis care. Maybe a patient with a recent ileostomy or colostomy. And so how do we care? Teaching patients how to care. These are, these teaching, maybe they're in for a couple of days within your swing bed program. Typically it's not very long-term, and I'd be interested to hear if folks have had what they've done in this regard around teaching and training and what that type of patient looks like for their program. But again, these typically, you know, once you get to that point that they're no longer meeting that skilled care, that they've kind of understood their proper care of their specialized dressing or skin treatments, you know, then they're at the point of discharge and no longer meeting that skilled care. So teaching and training, so very important as it relates to documentation around teaching and training. And what we want to encourage folks to do if you do have a patient that is in your swing bed program for teaching and training, is there's a few different things that we want to make sure that you're ensuring that you're capturing related to this. And, you know, some of the documentation of training here listed on this slide, you know, the description of the procedure being taught, the involvement of the patient or the caregiver in their response to that treatment, or sorry, that teaching, their description of the self-care, any type of teaching aids that were utilized, return demonstrations and retention of materials taught, which I think is key. The outcome of teach back, and hopefully, you know, a lot of organizations, whether it's, you know, during your discharge planning, or in discharging of patients, that you are utilizing, you know, best practice teach back methodology, and really having patients kind of recite and what they have just been taught. And then teaching the pacing, the energy conservation, diet, and, you know, making sure that that is all captured in our documentation. Sorry, this slide has a lot, but again, so there's also, we want to talk a little bit about rehab too. So a lot of, you know, what we see is there's a requirement that therapy has to be done at least 5 days a week when there's no other nursing or skilled needs. And so when we think about 5 days a week, a lot of times we'll hear from a lot of hospitals and organizations, well, we only have PT available Monday through Friday. We don't have anything on the weekends. It doesn't have to necessarily be, you know, 5 days in a row. It's at least 5 days in a week, however that can be achieved for your organization. You know, capturing some type of therapy on the weekend. Oftentimes that could be done by nursing, as long as they've been properly kind of educated and taught on the proper techniques for moving a patient specified by rehab and the rehab professionals. So when we're talking about rehab, you know, services may be different types of range of motion, strength, balance, coordination, endurance, functional ability, activities of daily living. There's also different therapeutic exercises and activities administered again by, you know, a PT or an OT, really ensuring that the safety of the patient and the effectiveness of the treatment as well. Gait evaluation and training, you know, making sure that we can restore function on a person's ability to walk. That it may be something that's been impaired by some neurological or muscular or skeletal abnormality. Range of motion exercises, certainly, and making sure that, again, as evidenced by a therapist note, showing the degree of motion lost and the degree of motion restored. So again, a little making sure that that is adequately documented and captured in the patient's medical record, really on those range of motion exercises. In maintenance therapy, you know, something that a qualified therapist is required to kind of design and establish a maintenance program. For some patients, might be for a patient with Parkinson's disease who has not been under a rehab regimen, and then may require some type of services by a qualified therapist to really determine what type of exercises would contribute to the most to the maintenance of their present level of functioning. So we get them to a good spot. How do we continue? That program is for them to continue to be functional at their current level. And then ultrasound, shortwave, and microwave therapy treatments, again, as administered by a qualified PT. And also some hot packed hydrocollators, infrared treatments, paraffin bath. Again, if this is administered by a qualified PT, or certainly required when doing these types of activities. And then any of the services by speech therapist or an audiologist when necessary for, speech and hearing would qualify. Respiratory. So again, there is a requirement. So if a physician order has indicated that there's some respiratory therapy that is required 7 days a week to be considered a skilled need. So that is important. Again, we often hear from hospitals, well, we don't have 24/7 respiratory therapy. We don't have it 7 days a week. So this is something that nursing can also do, but it's important that we make sure that documentation is in place, and that this even trickles down to even more is that we have documentation of the nursing doing the breathing treatments or respiratory activities, but then there's also needs to be nursing competencies need to be in personnel files in order to meet what CMS has ensured. And so again, making sure that there's lots of kind of checks here if we're going to have nursing do some of that to meet that 7-day requirement on skilled care. So in addition to following up on some of the respiratory therapy here, nursing may provide and put a charge in for respiratory treatments, but again, must have documentation in the personnel file, must document assessment and treatment, and must have a yearly competency updated, which again, updates must also be in that personnel file. So it can be, we can, capture respiratory therapy as a skilled need, but in order to meet that for some organizations who can't provide that 7 days a week, we can have nursing capture that as well. And then in the medical record, certainly as it relates to respiratory services, we have a plan of treatment in progress towards measurable goals. They are rendered appropriate. It was appropriately delivered by a qualified professional or practitioner. And all of the documentation supporting the medical necessities should be legible, maintained, and in the patient's record. And so again, we're going to go over lots of different things around the clinical documentation side of things, that you'll hear that a little bit more. And then lastly, and this is always a hot topic for some, is around end of life. And we get this question also quite a bit about, is end of life considered as skilled care? And we say maybe, and certainly it can be when maybe a rehab therapy may be needed, and improvement in a patient's condition may occur when, so you may have somebody that's terminally ill. They may begin to exhibit self-care, mobility, and or safety dependence requiring some type of skilled service. So again, we're not going to make them better, but we may not, they might have skilled services to not make them worse, if that makes sense. Hospice, though, is not a skilled service. We're not talking about hospice here. So some organizations may provide hospice services. This is really around kind of end of life care and meeting that potential skilled service for that particular patient. So it's all very dependent on, documentation as well. Getting your providers on board with this is also key and very important here. So interested to hear if some hospitals are providing that end of life within their care, within their swing bed program. Okay, so now shifting gears a little bit, and you probably noticed that a lot of, in order to meet some type of skilled service for our swing bed patient, there is the importance related to documentation, and so what I'm going to do is talk a little bit about, what is the purpose of medical documentation, and we'll talk a little bit about the specifics as it relates to swing bed documentation. So, really the primary purpose of the like a health record or a medical record documentation is really around kind of communicating between different providers, clinical staff, and it kind of really articulates a complete and accurate picture of the patient's medical condition. And it really allows you to document any of the care that they receive. It's a place where patients' health information and data resides. So data like demographics and things like, at home life, things like that are all within that patient medical record. The medical record is also a legal document. And so when you think about it, we need to making sure that it meets certain regulations, certain policies. So again, it is certainly a very, I would say, very important record and document as it relates to organizations as well as patients as well. And really, as it relates to being a legal health record, it really serves to document and support the decisions made on the patient's care, supports revenue sought from third-party payers, and again, it provides a legal testimony regarding the patient's illness or injury, response to treatment, or caregiver's decision, and serves as the organization's business and legal record. So, I'm sure you've heard, that, medical cases that have been brought into courts of law, and they go back to the medical record of that particular patient, and we have, for instance, and heaven forbid, but a nurse on the stand, and, they have an excerpt from the patient's medical record written by that nurse. Can that nurse, based on that description of what has been presented, can they adequately say what was actually going on with that patient? Is their level of documentation really truly capturing that patient's condition, the care that was received, the treatments, the outcomes? So again, heaven forbid that, that legal document ends up in a court of law. We need to make sure that we can stand behind what our part as clinical professionals goes into that medical record. So just as a caveat. And so what are some core characteristics of high quality clinical documentation? Well, we are, when I think about legible, you think about, well, we've moved from a patient, a paper system, hopefully, although I do still run into some organizations that are on paper, that, that we should have that our documentation's legible. But again, I think this translates over to the electronic versions of our documentation as well, making sure that our documentation is clear and not vague, really, again, fully describing what's wrong with the patient, and without being open to interpretation. So we can't leave gaps in our documentation, making sure our documentation is complete, really making sure that we can completely address the patient's issues or concerns, and thinking about chief complaint, reason for visit, working diagnosis, file diagnosis. In addition, the documentation contains the proper authentication by the provider, so signature and date. sometimes when we go in and do kind of mock surveys, we still have missing authorization from providers or authentication from providers, notes not signed, orders not signed. So again, making sure that that is complete. Consistent documentation, and should not be contradictory between providers or from one progress note to another. Precise. We want to make sure that if we have put in as much detail into our documentation, more information ensures that there's more accuracy in our clinical documentation. Is our documentation reliable? Is the treatment plan supported by the provider documentation in the health record? You know, we would hope so, that, you know, everything kind of aligns with our documentation or the treatment plan to what has been ordered by the physician. And then timely, of course. You know, we need to be timely in our documentation to ensure that timeliness in our change of care is appropriate. It all kind of follows along on this spectrum or related to timeliness. And of course, we have lots of various organizations that have various standards related to documentation, from CMS and Joint Commission to different payers. We have, and then different other kind of professional organizations as well. American Health Information Management Association. We have different certification and licensing groups, insurance carriers, workers' comp. Again, they all have some documentation standards that are out there as well. And within our organization, we likely have hospital documentation policies and procedures. And we, you know, this, you know, being two differences between documentation by inclusion and documentation by exception. And so what we mean by that and kind of the differences between the two, documentation by inclusion is really something that's kind of ongoing on a regular basis. It's the documentation that we consider are like your assessments and your findings, your interventions, patient outcomes. We think that documentation by inclusion is the belief that if it's not documented, it wasn't done. So very important there. Then there's documentation by exception. These are more or less the negative findings. So say if you have an assessment finding, interventions, or a patient outcome vary from the established assessment or norm or standards of care. So this is when you would, you know, have an abnormal finding. You would ensure that you're documenting that finding by exception. And then the belief is really around that all standards have been met with a normal or expected outcome unless documented otherwise. So again, the differences between the two. So a little bit about swing bed again. Swing bed documentation is really a combination of both inclusion and exception. When we're thinking about exception, it's for the daily system review. By inclusions related to the reason for admission or instance. So, you know, using some type of checkoff form or system review when documenting positive and negative findings, or using also using a checkoff form for all activities of daily living with space to comment on level of tolerance. So more of that free text or any of the continued issues as well. Some of our documentation goals are very important when it relates to our swing bed patients. And so we need to think about what is the communication of the patient's need and care provided, should demonstrate clinical decision-making whenever possible, and demonstrate the need for skilled care. Certainly, probably the highest as it relates to swing bed. And then compliance, certainly, And then best practices should be an important aspect and evident in our documentation. So what are some tips really for accurate documentation? If we are documenting, making sure that we're documenting any clinical issues, rehab treatments, ADLs, other functional areas, cognition, mood, changes in condition, new orders, those are areas in which we should we should make sure that we are providing accurate documentation on, and be sure that your notes reflect the individual patient. So I hear this a lot, and I hear this as it relates to moving into this EHR, electronic medical record, where we get so click, click, click heavy. And that oftentimes I've seen it, and I hate to say this, but I've seen some copy and pasting of notes between patients. And so we have to make sure that our notes really reflect the individual patient. And then more is not necessarily better. It's really kind of the quality of our notes too is really what counts. Quality over quantity, as they say. So so documentation that we need in the swing bed medical record. So we need, from an acute discharge, we need physician's orders, we need the physician discharge summary, and we need nursing and therapy discharge notes. Specific to our swing bed admissions, we need admitting orders. We need the physician H&P, comprehensive plan of care, and comprehensive assessment. We'll talk about those in just a minute. And then we have ongoing physician documentation as it relates to progress notes, to support visits. We have, reference to medical and physical progress, certainly if they're receiving any type of therapy or nursing rehab. And then a provider should also reassess every 30 days or as warranted based on the medical condition. So if we have, a patient that is, has not improved in 15 days or so, that may warrant, or has not shown any progress towards improvement, that may warrant a reassessment by a provider. Again, that may be less than that 30 days. And then we have Medicare certification as well. So this might be something that you might want to consider adding to your swing bed admission orders. But anytime we might have to recertify with Medicare after 14 days, and then every 30 days after, including any type of physician documentation, should support the need for the continued stay. So if we're getting past that 30 days, having those physician documentations to support that stay. So specific to the comprehensive assessment, so as you all are very familiar with that, again, this is really something that needs to be done if the patient remains in the swing bed setting. A reassessment should be completed after 14 days, what I just mentioned. And then a physician must reassess the patient every 30 days, depending on the medical condition. So what we always like to say is that the comprehensive assessment really should be something that an interdisciplinary team should complete. And who we think of as our interdisciplinary team, the physician, whether that or a hospital, and some hospitalists, maybe a nurse practitioner hospitalist, who may be involved in that, a nurse who kind of oversees and is responsible for the patient's care, an aide also who's heavily involved with the patient's care, nutritional services, and any other kind of health, or in addition, patient and family, very important there. And then any other healthcare professionals, certainly, maybe it's the PT that's involved, or maybe that patient has speech, social worker, pharmacy, again, depending on that needs of that patient. The assessment really process should include direct observation and communication with the patient, as well as communication with all the other interdisciplinary team members. So what does that comprehensive assessment include? Lots of things. Lots of things. And so again, a lot of organizations really have either broken out some of these requirements among their interdisciplinary team to report on, to bring forth. So again, lots of different components of the comprehensive assessment, discharge planning, different mood and behavior patterns, of course, the physical function, psychosocial well-being. I think we talked and hit a lot of these on when we were talking about the swing bed policies and procedures and what's required, and maybe what has changed, but certainly there's big highlights around the discharge planning as well. And then what we also have from a documentation perspective for our swing bed patients is the comprehensive care plan. And this is something that should it be included, it must be developed within 7 days after completion of the comprehensive assessment. And it should include kind of measurable objectives and timeframes to meet the needs that are listed in the care plan. It's certainly something that is reviewed by your interdisciplinary team on a pretty regular basis, and describes the services that will be rendered to this patient to really help the patient achieve their highest level of functioning, and also describe services that would be required but are not provided because they have the patient has exercised his or her right to refuse. So again, a lot of times, making sure that if a patient does refuse, say, therapy every single morning, documenting that, because if it's very important as a major component of that comprehensive care plan. And there's also admission assessments, and who is providing that. Nursing performs new assessments, but they can certainly bring kind of demographics from the acute care side. And they also, nursing will initiate the care plan, so on admission. Daily documentation is really going to be by your hospital policy for swing beds. So for folks, sometimes you've probably maybe never seen your hospital policy as it relates to swing bed documentation. So might be something to consider looking at, because how often do you hear, well, this is the way we do it, and this is the way we always have done it? Is it the way that your hospital policy has set forth? Just maybe a curiosity, if you will. So some of that daily documentation, having a system review at each shift or every 24 hours. It's not like nursing documentation of our acute care patients where it's happening, every 2 hours or every 1 hour, whatever your hospital policy has said. But your documentation for that daily, in that daily time frame, really must include any clinical findings, treatments, observation regarding those skilled needs, and functional status. And also asking yourself, do we have a process to ensure that nursing is aware of what we are skilling the patient for? So having that communication with our nursing staff on our swing bed patients. Who is a swing bed patient and what are they in for? What's their skills need? So they can be looking for that when they're doing their daily documentation. Oftentimes we hear that nursing documents the same with a swing bed as they do an acute. And, we don't have to do it the same or on the same level. So therapy, their role in the admission assessment. They certainly perform a new assessment. They develop their treatment plan and goals. They consider kind of pre-morbid functional level, present status, discharge plan. They set those therapeutic and functional goals, and they write the treatment plan that should be signed by the provider or clarification orders. Daily documentation for them really is around, when they come and see the patient. Is it morning or afternoon, as kind of described in the treatment plan, in any modalities used. Status and tolerance is certainly something that's recommended to be part of that daily documentation. On a weekly basis, reassessment for that patient is really based on any of the goals that are established. And then if the patient requires a reevaluation, maybe there's been change in the patient condition, then it may be billed for, and then really kind of a synopsis of status and continuation of the treatment plan happens on a weekly basis. And let's see. So also, you may have part of your interdisciplinary team. You might have a dietary. So a registered dietitian is only required if there are nutritional issues that are present. So if it's something that is ordered by a physician, and then you might have to have a registered dietitian do the initial treatment plan, initial assessment, and then maybe have a dietary tech with registered dietitian consult may also be acceptable for them. Dietary techs are sometimes used for routine diets when the registered dietitian is not involved. And it's also acceptable when you're doing nutritional screenings completed by nursing as part of the admission assessment. But if there is a finding that comes out of that nursing assessment, then a dietitian is called if that is something that is triggered on that assessment. And making sure, again, that you're documenting all of that care as well. And then, and also, and I just saw in the chat, new dietary guidelines require a dietary evaluation on every swing bed patient with at a minimal a reeval weekly. So thank you for that, Felicia, and interested to see how some folks are meeting that requirement. Are they having a hard time meeting that requirement? Certainly open when we get to, we have a couple more slides left, interested in that. And then, part of the admission assessment also includes the psychosocial assessment and an activity pursuit, which is also part of the care plan. So the psychosocial assessment, it may be completed as part of the nursing admission assessment or by case management, social worker, discharge planner. And it's part of the discharge planning assessment that also needs to be done as well. So, so depending on who is doing that in your organization, social worker will, in review from a master's prepared social worker is not required for swing bed. So you don't have to have a master's prepared social worker. As it relates to activity pursuit, this is something that may be incorporated into discharge planning in the psychosocial assessment. This could be performed by nursing if you have an activities person, although you don't need to have an activities person. Or it could be social worker, case manager, or somebody on your staff that's designated as an activities director. Sometimes we'll have some type of like occupational therapy could also be part of this capturing the activity pursuit, but should be considered kind of last resort. And dealing and ongoing documentation. So what's required, what should you, and who's responsible? So nursing, again, This is just kind of recapturing some of what we just talked about. Should be doing the shift and daily assessment, and then the reassessment after 14 days. Focus progress notes by exception. So again, daily documentation to support different observations, and then weekly update in the chart or in any type of interdisciplinary documentation form. So I know a lot of hospitals use different forms to make sure that every interdisciplinary team member is contributing to that form and getting those updates on the plan of care as well. Therapy has their daily treatment documentation, and then weekly or as needed review of status with documentation included. Then we have dietary, it's social worker, or some type of care management, case management, really involved in the discharge planning and activities. And then activity status, really part of the interdisciplinary form, and something that could be done by nursing in their daily forms, or maybe something that we can use an activity checkoff list and daily documentation. And lastly, as we've gone through really the patient experience rolled up into documentation, is documentation on discharge. So the the discharge summary, really a physician must prepare the discharge summary. And when we kind of anticipate discharging a patient from swing bed, and the various components of a discharge summary should include, the summary of the patient's stay, what services they received, what their healthcare status of at the time of discharge, reconciliation of meds, so pre-discharge meds with post-discharge medications as well. Where are they getting discharged to, whether it's home with family, home with home health, long-term care, and then a post-discharge plan of care. And this is something that you have participation with family and the patient. There's identification of the continuing care needs after discharge, how those will be met. Any preparation or education should be given to both family and patient prior to the discharge. So you're doing that discharge teaching, utilizing best practices around teach back and so forth. So lots that I just covered. I know that we have some time at the end here for some Q&A. So happy to answer any questions from you all. And so thank you again for Felicia on that. And then also Felicia added in the chat. We do, but only if patient requires IV comfort meds. Oh, this is related to the end of life care. And just as a reminder, recording will be available, as will the slides. Laura will be sending out the slides to you all. So I know there was a lot of text on some of these slides. So you'll have some time to review or share. Oh, great. Thanks. Yeah, thanks for sharing that example. Are any other organizations doing end of life in their swing bed program? How about anybody doing any type of teaching and training for their swing bed patients? Or is it just kind of as needed? You may see a patient come through for teaching and training, or do you have a hard time ensuring that patient meets skilled services? Yes, thanks, Felicia. Yep. Yeah, you don't have to have, as a critical access hospital, you don't have to have a specific activities program or even hire an activities director. But you can, a lot of hospitals with their swing bed patients, they really enjoy having a activities program set up. So, and it may be somebody that, you may have nursing, or you may have somebody that does those activities, those specific activities with that patient or your swing bed patients. I know I was just working with, oh gosh, where's this hospital? You know, it was a critical access hospital, and they just really enjoy doing some type of structured program 2 times a day, excuse me. And you know, once a week it's always bingo. And they just enjoy doing it. So they market that to their community and to their patient population about that part of their program. But again, it's not a requirement to have a structured program. Okay, so Lindsay just put in the chat here, as it pertains to therapy, if a new swing bed patient comes in the middle of the week, how flexible is the 5-day rule? Does it have to be 5 days in a row? No, so your therapy does not have to be a continuous 5 days. It has to be just 5 days in the week. So what I often hear is because you don't have rehab services many times on the weekends. So nursing will do some type of getting the patient up and moving them and doing some type of rehab for that patient over the weekend. But again, it does not have to be 5 days in a row. Any other questions? All right, I think I made it to time. Oh, and then yes. So evaluations, Felicia, thank you. Evaluations should be completed in 24 hours, and this should be taken into consideration on the weekends accepting. So your initial rehab therapy, physical therapy evaluation needs to be done within 24 hours of that patient being admitted into your swing bed program. So oftentimes when I'm seeing, you know, what do you do on late admissions on a Friday if you don't have rehab coverage on the weekends? You know, a lot of times, and so folks then do not accept that patient if it's coming in late. And so again, working with your referral sources to really say, you know, we don't have rehab coverage. This patient's going to need that initial evaluation within that 24 hours. Can you get them here in the morning? Or, you know, working with some of our referral sources to avoid that Friday late admission if you don't have rehab again on the weekends. Some organizations do have, you know, limited hours. They might come and capture a Sunday morning and capture any of the evals that the new patients that came in, or they might do a Saturday morning to just catch those evaluations. All right.
I'm not seeing any other. Oh, we do have another question that came in the chat. Is that all disciplines, or is it just at least one occupational or PT eval sufficient?
Yeah, so it is, and correct me if I'm wrong, it's any of the rehab. So PT and OT needs to be within, or PT needs to be within 24 hours. Yeah, either one. Yeah. Get Felicia with all the good insights. No, that's great. So thank you all. Really enjoyed the conversation. And again, reach out to Laura if there are any questions, or me directly. And we look forward to our next webinar.
Yes, thank you, Lindsay. If you get out of this call and you're like, hey, I have some questions, please feel free to email me. Also, if you're watching this recording and have questions or would like clarification, please email me as well. Our next webinar is actually scheduled in July, and I'll be sending out, once we have this recording uploaded, I'll send it out along with the registration link for our next webinar. So with that said, thank you guys. Everyone have a great day, and thank you, Lindsay.
Thank you.